you, Dan. Okay, so my name is Mary Hausler. I'm a pelvic floor physical therapist at the University of Iowa. I'm going to be speaking about how pelvic floor physical therapy plays a role in gender-affirming care for all queer identifying people. As I said, I'm one of four. We're in the basement of the hospital if you ever want to come see us. We're in the lower level. I say the dungeon, but listen to your heart. Natalie actually sees pediatrics, so anyone under the age of like 13, 14, I definitely recommend Natalie. But all of us are trained safe spaces and treat trans patients. There are three topics that I want to cover today. One is just education about what the pelvic floor is and what the scope of practice is for a pelvic floor physical therapist. The second will be specifically surrounding vaginoplasty, so what we do preoperatively and postoperatively in those periods. And then finally, addressing more social practices for trans folks, including binding, tucking, and packing. So the pelvic floor is a group of muscles. All genders have a pelvic floor, and it's just muscles, fascia tissue located within the pelvis. I even brought, this is my pelvis model. Her name is Shakira because her hips don't lie. But we currently don't have a penis owning model because they're weirdly very expensive. But we have a lot of other pictures and gender neutral photos as well that we can use that have different identifying captions or labels here, so if they're uncomfortable with the anatomical wording, we can use other words as well. But there's three main functions of the pelvic floor: bowel, bladder, and sexual function. But there's past that, there's some postural stability that comes in, as well as some support of those internal organs, and then also it's involved in the breathing mechanism. Your pelvic floor is the bottom portion of the piston that works with your diaphragm, which we'll talk about implications surrounding binding, tucking, and packing with that pistoning program. So when it comes to what we do as pelvic floor physical therapy, we talked about bladder, sexual function. So bladder-wise, we can talk about incontinence, urgency, frequency. Bowels the same way, it can be incontinence or constipation, hemorrhoids, irritable bowel syndrome. And then sexual dysfunction, so that could be pain with sexual activity, whether it's pain with insertion, pain with erections, ejaculation, premature ejaculation, and anorgasmia, or inability to achieve an orgasm. So I'd say that's some big things, but also just pain in general. When it comes to penis owners, we treat a lot of testicular pain, penile pain. Vagina owners, it's like vaginal pain, low abdominal pain, what people might call period cramps. But then I also treat ribs to knees, so hip pain, back pain, abdominal pain, really anything in there that might be painful is beneficial to see us. We do perinatal care, so anything around pregnancy, postpartum, and then pelvic organ prolapse. But my favorite patient, to be fair, has a problem in every space. So I love when people have incontinence, pain with sex, constipation, and pain. That's where we live, in that wheelhouse. When it comes to an appointment, your first appointment will be about 60 minutes. All follow-ups are 45. You're in a private treatment space with just one-on-one. You are welcome to bring a partner with you or a support person. We also offer chaperones. That could just be another employee that we can bring in the room for your safety and comfort. But we can do internal assessments. This is very much up to the safety and comfort of the patient though. An internal assessment is not required in our space, and it's kind of at the pace of the patient. I have treated many patients in which I've never touched their pelvic floor or touched their pelvis at all. And so that is a clear consent and readiness barrier for us. But what that is either a vaginal exam or a rectal exam. It's just one finger. I tell vaginal or vagina owners that I don't use stirrups or a speculum, so I've been told I'm the nicest internal exam, but the bar is low. So when we do the internal assessment, I'm looking for multiple things: tenderness, hypersensitivity, stiffness, response to that movement and stretch, as well as its function. Can you contract? Can you relax? Can you push out? The three things those muscles should be able to do, can you do them? But then when it comes to a full assessment of the patient, there's also external assessment. So we look at the lumbopelvic complex, your hip alignment and strength, The pudendal nerve is a nerve that innervates pretty much the entire pelvic floor, and sometimes there's irritability within what's called the Alcock's canal, or inside that sit bone. As well as skin assessment. I work in the vulvovaginal disease clinic as well, so I have a wide range of knowledge surrounding skin conditions and disorders. And then obturator internus is a pelvic floor muscle that lives both inside and outside the pelvic floor that we tend to assess as well. So when it comes to specifically vaginoplasties, pre-surgery, you should come see us. That's the goal. All of the providers that do vaginoplasties automatically refer patients to us. And it's first to make sure that your pelvic floor is doing okay going into the surgery. A good pelvic floor going in is a good pelvic floor going out. So we want to make sure we're addressing any bowel, bladder, sexual function complaints prior. I do know sexual function can be a difficult topic for folks with gender dysphoria. So we want to make sure all of that is resolved prior to surgery. We talk about pressure management. If you're going to work hard to get a vagina prior to surgery, we're going to make sure that you can manage it and keep the space healing while following. We'll talk about abdominal breathing, making sure that piston is working well, as well as constipation management, ILU massage, abdominal massage, and then we'll go through what that post-exercise expectations look like, as well as making sure they buy dilators. So dilators are the biggest, most important exercise post-op. I have what we recommend with me today. It's from Soul Source. These dilators are gold standard. I wrote the program for dilating post-operatively, so we'll go through that here in a second, but we want to make sure they buy these ahead of time and are prepared. Again, if you're going to work that hard to achieve your vagina, we're going to make sure that we keep it. Post-op, as we said, we talked about abdominal massage, pressure management, belly breathing, but then there's some just blood clot management. Any surgery can lead to blood clots, so we want to make sure that they are prevented post-operatively. When you're at the University of Iowa and receive your vaginoplasty, there's going to be no physical therapist that comes see you, mostly because we want to ensure physical therapists are a safe space, and they don't really understand this procedure well, and so then it's on us to make sure that you're managing that post-op well. I also just think it's cool to see what becomes what in a vaginoplasty. So when it comes to the tissue that creates the vaginal canal, it is part of the skin tissue from the penis, as well as some of the scrotal tissue that gets inverted up and into the pelvic girdle. The glands of the penis becomes the new clitoris, and the urethra is slightly changed in its position. And then the labial tissue is actually scrotal tissue that forms the lips. They very much look like any vulva. It's very impressive. So these are the dilators that I was talking about. When it comes to creating our program at the University of Iowa, I did extensive research to ensure we kind of take the most conservative approach. We want to make sure that we are maintaining that as safely as possible, and so we start with you dilating 30 minutes 3 times a day, progressing the size as tolerated. So you'll start with the smaller ones, working your way up through the sizes. Eventually, a year out, you'll only be dilating 30 minutes 1 time a week, but you always take a step back if you feel like size or depth regresses. We can always work on dilation, right? We can make it so that the vaginal canal can accommodate more leg girth. But once you start to lose depth, that's something really, really difficult to gain back, and oftentimes requires a surgical revision, which is really another difficult recovery. And so our goal is to make sure that depth is our main focus, and that's something that we really push in our preoperative appointment. And then post-op, we also just make sure all those things are working again. It's pretty much the goal. When it comes to the social transition considerations, binding is a major one, because 87% of transmasculine folks bind regularly, and they often bind quote-unquote too much, 7 days a week, averaging 10 hours a day. So my goal is always to keep patients as safe as possible. I have a current patient that is a 15-year-old at a local high school who needs to bind all day at school and then has after-school activities and then works on the weekend and needs to present in a safe way. So it's really difficult to work with those patients that don't have off days or need to be binding for long periods of time. So our goal is just to educate them as much as possible about safe wear schedules. In fact, the encouragement is wearing for 8 hours at a time. Having off days, my goal is always the weekends, but I understand if that's not possible. And then we're educating on when to remove. Like sleeping and exercise are obviously times to remove that pressure, but also if symptoms are occurring. So back pain, skin breakdown. If you bind too much, the tissue can break down and then you are not available for a top surgery if the skin isn't healthy enough. And so I always tell folks the discomfort today is benefiting tomorrow, and so it's making sure that that skin is healthy enough to go through a top surgery. We go through recommended binders. Young trans patients are just trying to bind with whatever materials they have, which I appreciate, but we want to make sure it's done as safely as possible. So we talk about different commercial binders, secondhand binders if you feel like you can't afford on-market stuff, as well as just compression shirts and sports bras. And then we talk about unsafe binding practices using elastic bandages, tape, and plastic wrap. All of that leads to too much skin breakdown and moisture buildup. And the elastic bandages are actually too much compression and poorly managed compression. When it comes to exercises, we'll go through a lot of just chest stretching. When it comes to trans masculine folks, they tend to do a more curved posturing to reduce that breast tissue, understandably. However, this leads to a lot of stretched muscles in the back, tight muscles in the front, and can lead to some disordered breathing and pain. So it's all of our exercises are about opening that chest, whether it's pec stretches or pec releases, and then thoracic mobility, that upper back. So we'll do some open books, we'll do some thread the needle exercises. I see currently a trans man who did do top surgery probably a year ago. Went to Katie and Boric at the University of Iowa with thoracic pain or upper back pain. And even a year post-op is still experiencing it from his binding years. And so I do what's called trigger point dry needling. I'm a high certified dry needler at the university. And it's a way to break up muscle knots better, faster, stronger. I started in pro sports because, God forbid, Caitlin Clark is off the court. It trickled down to us peasants who got millions of dollars, but we still have pain. And it's a way to break up those muscle knots more immediately and for lasting longer. And so I dry needle around the spine, and his pain has been eliminated, and he can participate. He's a burlesque dancer, and is now no longer limited in what he does. It's awesome. When it comes to tucking, only 5 to 13% of trans women have bottom surgery, so tucking is a really awesome, cheap, easy way to feel affirmed. Annoyingly, there's not a lot of studies on the negative effects of tucking. There is some literature about infertility, just because the testicles being up in the body are held at a higher temperature, which could lead to sperm issues. Like the reason they hang low is to keep the temperature regulated lower than the body temperature. But the literature is really weak. So when it comes to fertility, I often recommend just getting tested. Super easy. You can just ask your physician. But don't not tuck because fertility is your problem or your concern. When it comes to tucking, I often just talk about how to do it again safely. You want to do medical tape or snug underwear. These are homemade gaves, I don't know how to say it, or a dance belt. All of this creates a flat effect. We just want to avoid really abrasive uses like duct tape. All of that can again lead to skin breakdown and discomfort going forward. So we kind of guide this, but also a lot of times my trans feminine patients know their best technique and they have a safe way they do it already. So then we talk about, from a physical therapy point, more of posture. Again, to hide the bulge, and kind of like trans masculine, they tend to round their shoulders. Trans feminine try to anteriorly tilt their pelvis to hide that bulge, and also just give a more feminine presenting body where they kind of stick out their booty and their chest at once. This can lead to a lot of dysfunctions. We tend to get our hip flexors are then shortened, our hamstrings are stretched, our low back is shortened, so this leads to a lot of muscular dysfunction and muscular imbalance around the pelvis. So we talk about posture training, and again, if you're in this while out in the world and this is how you feel safest to present, then it's about managing it after and getting stretches that would be appropriate for the muscles that are on in a shortened position. We again advise on wear schedule. The difficult thing about tucking is then how do you pee? So if you're out in the world and you go to the restroom, you have to tuck again. So on average, you empty your bladder every 2 to 4 hours, so we tend to recommend about every 2. We assist in skin management, healthy bladder habits, right? So a lot of times folks will dehydrate themselves and then so they don't have to use the restroom, which I mean a lot of folks do, right? Teachers tend to not pee very often, nurses do the same thing. So it's just about promoting those healthy bladder habits. And then oftentimes they experience testicular pain. So it's about finding the root of that testicular pain, which might not be tucking itself, but treating that. Packing is when you use artificial penis. So there's a ton of different ones, everywhere from soft packing, which can be crocheted, or there's these really awesome like silicone versions. Hard packers, or they're called pack and plays, can form erections. And this whole like inner system can be moved and adjusted, as well as STPs or stand-to-Ps. When it comes to our role as a pelvic floor therapist, it's just discussing with the patient what their goals are, right? So if they just want to have a penis in between their legs and they just want that feeling and that sensation, soft packing is the easiest way with the least side effects. Hard packers are just a little bit bigger and tend to need more adhesive, whereas these can be placed in like pockets and pinned onto things. And then stand-to-Ps are the most difficult, mostly because vagina owners have never practiced urination in standing, and we don't know how to relax those muscles that well. And so we also do some guided stand-to-P training. Oftentimes I have people practice in the shower. Although it's not always recommended to pee in the shower because it can create habits, but learning how to relax those muscles in standing without having to aim is something that's really important. Again, assisting in skin management and gait training. When you add something in between your legs, you're going to start to walk maybe a little funnier than you were before, and so we want to make sure that they keep their gait the same without the packer as with the packer. So that's a quick summary of all roles of the pelvic floor therapist. I think the biggest takeaway that I would want anyone at home to know is that we exist. We are here to help. Again, my name is Mary Hausler. I'm at the university. When it comes to physical therapy, we are a direct access state, which means if you have Blue Cross Blue Shield, United Health, you can just call the university and ask for an appointment. You don't need a referral. If you have any state insurances, so Medicare, Medicaid, it does require a referral, so I recommend reaching out to your primary care provider or any of your LGBTQ providers to get you to us. I typically book for about 6 to 8 weeks right now, so it's not a tomorrow appointment, but it is typically covered by insurance and decently easy to get in. And if you have any questions, you can reach out to me at mary-hausler@uiowa.edu. Calling our department, you probably won't get a hold of me. You'll get a hold of our front desk, and then they'll tell me to email you. So.